So I'm an endocrine surgeon, and I wanted to start by explaining a little bit of what an endocrine surgeon is. A lot of patients are confused, as well as doctors, because of the endocrinology in the name, but I'm actually a surgeon that operates on organs that produce hormones, right? So a majority of 95% of my practice is actually thyroid and parathyroid, and others choose to do pancreas and some adrenals as well. So most of my patients, my family, my friends always ask me, what's going on with these thyroid nodules? So I thought I'd talk about that a little bit. So let's start with talking about what the thyroid gland actually is. So it's a little butterfly shaped gland that's really located lower in your neck. And the job is really to make sure your metabolism is working. It regulates your metabolism. It produces thyroid hormone, and the thyroid hormone that basically makes sure that your energy is good, you stay warm, and then the organs keep working as they should, right? Metabolism. So, what are thyroid nodules? Well, they're growth of thyroid cells that just go a little bit out of control sometimes, and they form a lump within the gland. It's a very common misconception to think that the nodules kind of hang off the gland, but the nodules are actually inside the gland. They're extremely common. Up to 10% of women and 5% of men have them, and as we get older, the chances of having nodules go up. And so kind of my rule of thumb is you get a 60% chance of having thyroid nodules by the age of 60 in women, okay? The good news is the majority, and the vast majority, like 95% of the nodules are benign or non-cancerous, not malignant. And there's a very small portion, about 5%, that do have cancer in them. All right, so what are some of the symptoms, right? Patients are like, well, I don't have any symptoms. Well, that's because majority of the thyroid nodules don't cause any symptoms. The tests are almost very often, almost always normal. Even if the patient has cancer, then the thyroid function almost always is normal. Kind of think of thyroid issues as kind of two categories, functional and structural, and you'll kind of hear that throughout the presentation. The nodules can be both, but they're mostly structural. And then functional derangements, that is something that we can see on the blood work. So sometimes the thyroid nodules can produce too much hormone. It's called hyperthyroidism, so too much, hyper. Rarely, the nodules can cause some discomfort in the neck, especially if you have a nodule that grows very rapidly. For example, if it's filled with fluid, then it can cause some pain. The nodules can be large enough to actually cause what's called compressive symptoms, right? The thyroid sits on the breathing tube or the windpipe, and the swallowing tube or the esophagus sits directly behind the windpipe. And so you can, if the nodules grow large enough, have difficulty breathing if it compresses the windpipe, or swallowing, and very, very rarely you can have hoarseness from that. So how are they found? Well, majority are found by accident. Certainly, we can find nodules on exam, either by yourself or by a physician. Sometimes, patients who get facials, they get found when the neck is very extended, or when you get your hair done. Those are really kind of nice positions because the thyroid comes up into the neck. And so at that point, if you have a large enough nodule, it can be seen or identified. But majority of them are actually found incidentally. If you get an evaluation for your carotid arteries by accident, you could find a nodule on the thyroid. Or if you get a CT scan for chest, you can catch a little bit of the thyroid on it, or the neck or the head. So sometimes those tests can show a nodule in the thyroid. Sometimes if the blood tests for the thyroid function are atypical, a physician may order an ultrasound that can identify the nodules as well. causes it? I get that question all the time. What did I do to get the nodules? And we really don't know exactly what causes them. There are certain things that increase the risk. So Hashimoto's thyroiditis, and that's an autoimmune process where your own body kind of attacks your thyroid. That has an increased risk for thyroid nodules. And also iodine deficiency, which is extremely uncommon in the United States because we have iodinized salt. If you eat fish or sushi or anything to do from the sea, you get enough iodine, so it just doesn't happen here. So we don't know, it must be something environmental, we just didn't find it yet. Well, how do we evaluate it once we find the nodule? Well, obviously laboratory tests, and I'll spend a second on that because whether you have thyroid nodules or not, your physicians probably get thyroid function at least once a year. So there's two tests that we look at. The actual thyroid hormone, and you will see T4 or T3. Those are the actual hormones produced by the thyroid gland, and that gives us a snapshot of what's happening in your body at the time of the blood test, okay? The TSH is a thyroid stimulating hormone, and that's a hormone actually produced in the brain, but it's a really good test to look at over specific time. So it's over weeks to months of what's happening with your thyroid. So if your thyroid is producing too much, your TSH, your brain hormone, is going to be suppressed. If your thyroid is not producing enough hormone, your TSH is going to be high because it's going to try to stimulate your thyroid to make more. Okay, so that's kind of how you interpret it. If the nodule meets specific criteria on ultrasound, such as size, the shape, the echogenicity, does it look similar to the thyroid gland around it? Is it hypo, echogenic? So all of these criteria in the ultrasound will then give us an idea of whether the nodule should be biopsied or not. And the biopsy is done using an ultrasound because you want to make sure that the needle is guided to the most concerning part of the nodule and the most meaty, the most cellular part of the nodule. So it's important to do this with an ultrasound. And it's done with a very, very small needle. It's tolerated extremely well, absolutely without any anesthesia. But of course, it can be done with a little bit of topical, but unnecessary in 99% of the time. Usually nodules that are under 1 centimeter, we really do not biopsy unless it looks super concerning or the patient has really high risks for having thyroid cancer. All right, so once you have the result of the biopsy, what can it be, right? So, and there's a special system, and the reason we have the system is so that the physicians can talk to each other easily. And so it's called the BETHESDA classification. But bottom line is that once the cells are extracted for the biopsy, the cytologist looks at the cells and then gives you a grade, okay? And the grade can be anywhere from 1 to 6. So if you get a grade of 1, that means that there are just not enough cells to have any opinion about what the nodule is, okay? It occurs very rarely, especially if you go with somebody who does them all the time and it's done with an ultrasound. Mostly the nodule that comes up as Bethesda 1 are really cystic. It has a lot of fluid, not a lot of cells. And in that case, we could just repeat the biopsy to get more cells. If it's a grade of 2, the nodule is benign. There's enough cells, the cells look normal, and that occurs in the majority of the biopsies. The risk of that result being false, meaning they're saying it's not cancerous, but there's actually cancer in it, is really low. It's less than 3%. So it's a really good test. And then let's go to the other extreme. It's a 5 or a 6. Then it's pretty suspicious, and those patients really happen only 5% of the time, right? And that's really good because it's very low chance. And I want to just a little bit of time on the gray area. There's always a gray area, and that occurs if you get a 3 or a 4. So what the cytologist is seeing are cells that don't look normal, so they can't give you a 2, a low grade, and they don't look really that bad to get a 5 or a 6, but there's something weird about the cells or atypical. And so then you get this grade of 3 or 4, and it's the gray area. It occurs about 25% of the time. So if you fall into that category, the chances of having cancer in that nodule now goes up to about 15–20%. But even with that, that means 80% of the people will have an unnecessary surgery. So we have a second test. It's a reflex test. So what that means that if you fall into this category, then automatically we do the genetic test. And the genetic test is not of your whole body, it's just of the nodule. And that genetic test tells us, are there any genetic changes that we know of that have a higher risk of having cancer in the nodule? And if there aren't any genetic changes, well then we feel better about the nodule, right? And I'll talk to you about that in just a second. If there are some genetic changes, depending on what they are, we then make our recommendations. And there are several companies out there that do the genetic testing, mostly covered by insurance. And I've used all of them. I mostly prefer to use ThyroSeq, but all of them are pretty good at giving some idea of what's happening in these gray area nodules. All right, so let's talk about treatment. What do we do with the nodules? Well, if the nodule is producing too much hormone or it's hyperactive, then we'll do a secondary test, okay? It's called a thyroid uptake test or a nuclear medicine scan. And what we're looking for is to figure out, where is this thyroid hormone elevation coming from? Is it coming from the whole thyroid, meaning like a Graves' disease type of situation where it's an autoimmune process and your thyroid is just hyperproducing from the whole gland? You would see something like this or something like this, where the red image shows the whole gland. Or is it coming from the nodule that we found? Just something like this, and the rest of the gland is a little bit suppressed. If the nodule is what's causing the elevated thyroid function, the chances that this is cancer is really low, and it really does not need a biopsy. And if you have a cold nodule, meaning the whole thyroid is producing the hyperactivity, but the actual nodule is doing not much, that's when we need to do the biopsy, okay? So if you have a hyperactive nodule, you can either do surgery or radioactive iodine, which is a little pill that has radioactive isotope on it. And when you take it, the hyperactive cells, they eat up that iodine and die, and that's the idea. When you have a Graves' disease type of picture, majority of patients, minus some patients that meet specific criteria for surgery, usually get radioactive iodine because you're trying to affect the whole gland. When you have a thyroid nodule that's overactive, surgery is better just because you can target your surgery to that lobe and leave the other side untouched and unaffected. So if it's a nodule, usually surgery is a better option. All right. If it's a benign nodule on biopsy, so you get a grade of 2 on the FNA, on the fine needle aspiration, then we need to follow it. So remember, there's a small chance that the biopsy is wrong. And so we really don't want to leave it up to chance. We really need to follow it with a repeat ultrasound. And what are we looking for? We're looking to make sure that the nodule isn't changing on ultrasound and isn't growing. We consider surgery for patients with benign nodules if the patient has symptoms, right? Difficulty breathing, difficulty swallowing, pain or pressure, or if the nodule is consistently enlarging on multiple consecutive ultrasounds. Then we begin to get concerned, well, will you have those symptoms if it's getting really large, or is there something we're missing within the nodule? Indeterminate, that gray area, nodules, we do get the genetic test, and then the genetic test really guides us to whether we should just watch it. So if the genetic test is completely negative, there are no genetic changes, then we can just watch it and treat it as though the nodule is benign. Or if the genetics test does find some genetic changes, then we can go ahead and offer what's called a diagnostic lobectomy. And that means that we will remove the lobe or the wing of the thyroid with the suspicious nodule to then have a diagnosis. And then during that time, we can evaluate the lymph nodes around the thyroid to see if they're of any concern, to make further decisions whether to remove the other side. But majority of the time, this really is a diagnostic surgery that we're doing. The next is if you get a 5 or 6 on the biopsy, and I'll spend a little bit more time about the thyroid cancer. So just some general information. It is the most common endocrine cancer, more common in women than men. Its cause is again unknown, but there are some risk factors that we know. So radiation in childhood or treatment. So, patients that were around Chernobyl, for example, are at a much higher risk. Or if you had treatment, something like a Hodgkin's lymphoma, radiation to the chest, head or neck, you will have a higher risk of thyroid cancer. Or if there's a family history, then you also would a little bit of a higher risk. But most have excellent prognosis, and that's definitely the good news. There's several types of cancer, and I'm not going to go into too much detail, but basically we kind of break it down into the different cells that they come from. So there's papillary, follicular, and Hürthle. They come from follicular cells. There's the medullary cancer, it comes from C cells. And then there's the undifferentiated, meaning when you look at the cells, the cytologists and pathologists can't really tell what line it comes from. This is extremely rare, less than 1% of the cancers in thyroid. So let's talk about papillary. Papillary thyroid cancer is the most common, 80%. It is the best prognosis, very slow growing most of the time, and it commonly spreads to the lymph nodes, but even with that, prognosis is excellent. Follicular is the next most common. It does not spread through the lymph nodes, it spreads by blood. And there's a subtype, you may hear the word Hürthle cell. It's kind of like the unwanted step parent or something from the follicular and the papillary or stepchild. And it kind of takes the worst qualities from both, but it still has decent prognosis, just doesn't take up radioactive iodine as much. And this one does spread to others as any cancer would, but again, it's quite rare. Medullary is the next one. It's pretty uncommon, only 5% of the time. The important things to take away from this is that most of them occur sporadically, not genetically, but about 20% do have a genetic lineage, right? So if you have a family history of someone in having medullary thyroid cancer, that's definitely something you should let your physician know about. And the one most important thing to take away from this slide is if you or your family member gets diagnosed with medullary cancer, they really need to get checked for this RET gene, because that predisposes patients to have other issues in other organs, and then it can certainly be passed down. So it's important for the offsprings to know about that. So what's the workup? The first thing is you need a really good ultrasound. I prefer to do my ultrasounds myself, either before surgery or right before the incision, so that I don't have any surprises. I want to make sure that I see where the nodule is and what the lymph nodes around it looks like. So if there's some worrisome lymph nodes, really need to be worked out by another biopsy to make sure that we don't have to extend surgery. We need some baseline thyroid functions, and a lot of patients would require medical clearance because it's a general anesthesia, and I'll talk to you about that in a second. So the most important treatment for thyroid cancer is surgery, and the there's really no substitution for really good initial surgery. You may be offered a total thyroidectomy, meaning your whole thyroid removed, hemithyroidectomy, meaning half of your thyroid removed, and you may hear the words lymph node dissection, meaning cleaning the lymph nodes around the thyroid. After surgery, you may or may not be offered radioactive iodine ablation, and that's very similar to what I mentioned when dealing with hyperactive nodules, just a little bit of a different dose. But it's basically the idea is once all of the thyroid is removed and all the disease that visually identified cleared by good surgery, there's always maybe some cells that may have escaped that I cannot see, for example, and that is when radioactive iodine is useful. We would make those cells really, really hungry and then give radioactive iodine. Those cells will eat them and they will die, and that's kind of the idea, simplified idea of what radioactive iodine does. And then, of course, replacing your thyroid with thyroid hormone replacement. So a couple of words about surgery, just because that's what I do. So the number one thing is to find an experienced surgeon. That's very, very important. The best outcomes, there are a lot of studies have been done on that, and the best outcomes come from surgeons that do at a minimum of 100 cases a year. In my practice, we do about 300 cases a year. So you really want somebody very experienced in knowing what the parathyroid looks like, what the thyroid looks like, what the bad lymph nodes look like, how to find the nerves. It's again done under general anesthesia, which is why some patients may require medical clearance. Most of it is outpatient. I either send patients home same day or the morning of the next day. And the surgery can last anywhere from 45 minutes to 3.5 hours, depending on the extent of surgery. And we can do it through a very small incision in your neck and a natural crease, and patients a majority of the time heal fabulously. The risks are quite low, again, if you go to a surgeon that is very experienced. Bleeding infection less than 2%. I mentioned that there's a nerve that goes to your vocal cords, and chances that it's permanently damaged and you'll be hoarse is less than 1%. Even with that, there are things we can do down the line to make your voice pretty close to normal, if not completely normal. And then there are these little parathyroid glands that sit in the back of the thyroid, and it's important to preserve at least 1 or 2 of them. You really just need 1 to function normally, but you know, the more you preserve, of course, the better. The chances that none of them work is about less than 2% in experienced hands. Recovery is really fast, anywhere from 3 to 7 days, depending on how fast you clear the anesthesia out of your body. Most people just complain of some sore throat and a little bit of incisional pain, and most people do not require any narcotic medication. And there's no restriction. You can eat, talk, move, kind of back to normal as much as you feel up to it. The follow-up really include laboratory studies, and depending on obviously your type of cancer, and then neck ultrasound. This is very important because it's a really good test to look at any recurrences, any lymph nodes. It's the best test, better than a CT scan or a PET scan, to look at neck recurrence is an ultrasound. There's other tests like a thyroid uptake scan, but usually most patients will require a laboratory and an ultrasound by a good practitioner for the ultrasound as well. So kind of to take home points, right? Thyroid nodules are extremely common, and only a very, very small amount of them are malignant. Majority of them are benign. It's just a nuisance that you're going to have to kind of work up and you know, get all worked up about, but most of them are going to be benign. Surgery for benign nodules really only if they're symptomatic, they're growing or hyperactive, and thyroid cancer is rare. Papillary is the most common and fabulous best prognosis. It's important if it is thyroid cancer, to find an excellent surgeon that has a lot of cases, that does a lot of cases every year where the risks become much lower. And of course, a multidisciplinary team is also important in taking care of you. And just remember, you're not alone. There's a lot of great groups out there that help patients with thyroid cancer, thyroid nodules, and of course we're here to help. That's what we do, right? So thank you so much for listening. I hope this was somewhat educational, and then I'll take any questions. Thank you.
Okay, thank you so much, Dr. Kundel. That was excellent, very comprehensive. There are a couple of questions.
Great.
One of the first ones, someone had asked, not so much about the surgery, but someone had mentioned that they have concerns about the accuracy of the basic thyroid tests. I guess they say that, that there are more specific tests that doctors don't always seem to do, and they're just wondering your feelings about that, about those levels of accurate, tests.
So if I had to guess, I think you're talking about the antibodies. So, obviously correct me if I'm wrong, but when we start, we kind of want to get a general understanding of what the blood work entails, right? So like I mentioned, T3, T4, it gives us a snapshot of what's happening with the thyroid at the time of the blood draw. And then the TSH kind of gives us an idea of what your brain sees over a specific longer time. So weeks to months. And if those tests show any abnormality, then we can go ahead and get the antibodies. And what the antibodies tell us is whether there is an autoimmune process happening. It'll give us an idea of whether or not you are more likely to need medication at some point in your life. It doesn't necessarily mean that if the antibodies are abnormal, that you will need any medication at the time if your thyroid function, like TSH and T3, T4, is normal. So it's not always necessary to obtain the antibody tests. I think that's what.
Yeah, probably what they're. Thank you. Someone else had mentioned, again, not so much related to surgery, but there's a lot of information out there about supplements. Supplements that can, help with any thyroid dysfunction. Do you have any feelings about this? Any ideas?
Honestly, I haven't read any really good randomized controlled papers that really are gonna make me want to prescribe it to everybody. I think it's, nutrition is important. Like I said, we really don't know what's causing the thyroid nodules. Something must be environmental, but it's really hard to tell you to go ahead and start taking all these vitamins, because again, they're really not regulated by FDA. There's really no huge trials to say there may cause, bad side effects. So I really can't tell you one way or another to take them. I think just in general, good nutrition will kind of help you, but there's nothing specific at the top of my mind to recommend.
Okay, thank you. And just one more question.
Sure.
Is there any literature out there or statistics on the reoccurrence of any thyroid cancers that, kind of come back more easily? Any particular ones that do?
Yes, I mean, obviously there is. So it's it's a very long-winded kind of answer that I need a lot of time for, but it depends on a lot of things. Number one, it depends on the type of thyroid cancer that a patient has. Medullary and follicular may recur more. Papillary also may recur, but it also depends on what the pathology is like at the time of diagnosis, what the lymph node status is. In papillary, for example, I talk about that because that's the most common that we see. If you have lymph nodes identified that are positive, then you obviously have a slightly higher recurrence. We also look at the number of lymph nodes and the extent of disease within the lymph nodes to give us an idea of recurrence. So it's not just, you know, one thing that we look at. It's a kind of a global evaluation of pathology and the test afterwards to give us an idea of what the percent of recurrence is for each particular patient.
Oh, thank you so much. So this was wonderful. Thank you so much, Dr. Kundel. Really appreciate your time and your interesting and comprehensive program.